So it is my pleasure to be with you. Next slide, please. Next slide, please. Thank you. To correspond, okay. To correspond with the theme of the meeting, I've structured my presentation into before and after in relation to the establishment of the UHC policy. And then I will end my presentation with some key messages. As you have seen in the previous presentation, to attain UHC, both health service coverage and health insurance coverage must be given equal importance. Over the past 50 years, Thailand has made a large-scale investment in public health infrastructure. This is to ensure that all communities have state-run health facilities that are frontlined by primary care units with a well-established referral system. Several government initiatives have also been put in place over the same decades to keep health personnel in rural areas. The overall aim of these strategies was to encourage people to seek care as well as referral at health units close to home. Next slide, please. Yes, thank you. During the same period, Thailand has introduced many health insurance plans into the health system. The first major program was implemented in 1975 to provide coverage for the poor, the elderly, the children, and the other underprivileged groups. But the efficacy of the program was hindered by ineffective targeting and insufficient funding. Two additional programs were later established for public employees in 1980 and private employees in 1990. Both programs continue operating to this day. Voluntary insurance program was the last to be introduced in an effort to provide financial coverage for the informal sector workers. But no sooner had it been implemented than it was encountering the problem caused by its voluntary nature. Next slide, please. Many policy experts had been toying with the idea of expanding the formal sector insurance programs to the rest of the population, but they had to dismiss it as being too problematic since the programs were designed for specific populations. And the idea itself was also met with fierce resistance from the beneficiaries. So around the turn of the millennium, they finally agreed on the ultimate solution, which was to abolish the public assistance program for the poor and the voluntary insurance program, and then to legalize the creation of another tax-financed program to cover the majority uninsured, which accounted for over 70% of the population. Next slide, please. So due to the extensiveness of its coverage, this new program is known as Universal Coverage Scheme. The success of its launch in 2001 could be attributed to the synergy of three important factors: strong political commitment, strong technical acumen, and strong societal support. And the key person who synergized these three agents was the late Dr. Sungwon Nitayarampong. A heart-rending experience witnessed during his early years as director in a rural hospital has strengthened his determination to make health security for Thai people a reality. His undergraduate experience as president of the student body had also sharpened his leadership skills. And so through his persuasion, the right to health insurance for Thais is finally enshrined in the National Health Security Act, as you can see on the right side. This landmark legislation established the Universal Coverage Scheme in 2002 as a safety net to all Thais who have no entitlement to state-sponsored employee health plans. And the scheme is directed by the National Health Security Board which is chaired by the health minister and consisted of representatives from various stakeholder groups. Next slide, please. So to summarize my first part of the presentation, Thailand UHC achievement could not have come to pass without this whole combination of a passionate policy champion, a supportive political climate, a supportive group of expert and civil societies, and a solid public health infrastructure. Next slide, please. But that was just the beginning. From that point onward, Thailand's UHC policy, represented by the Universal Coverage Scheme, has to go through non-stop improvement cycles to ensure that it can afford to cover needed services that keep emerging throughout the years in a way that will not break the government nor displease care providers and the beneficiaries. Next slide, please. Thank you. 20 years on, the scheme has evolved to provide financial risk protection for a broad spectrum of services. Some costly conditions such as renal replacement therapy and chronic illnesses need separate government allocations. And for areas that require multi-sectoral action, such as community health prevention, long-term care, and disability care, in this case, financial contributions from the local administration offices are solicited. Various forms of collaboration have emerged as a result. From working solely with state-run health facilities, the scheme has partnered with local administration offices as well as private entities, such as pharmacies, rehabilitation clinics, traditional medicine clinics, and civil society groups. And all in all, the satisfaction of the providers is starting to catch up with that of the beneficiaries, and the broad reach of the scheme has also generated sustained support from the Thai electorate, which may explain why the government expenditure on health remains consistently high at around 17 to 20% of the its overall expenditure. Next slide, please. Many challenges remain. First, with only 10% of the population being above the poverty line, the scheme has no choice but to continue financing from public money. Second, despite attempts to control costs, rising costs will always be an issue. And third, the prevalence of preventable and controllable conditions continue to be a burden on its expenditure. Fourth, problems such as road traffic accident, air pollution, teenage pregnancy, and unhealthy aging need multi-sectoral action. And lastly, since the scheme is operating in a multi-scheme model without a unifying mechanism, it has to ensure that its limited budget is spent efficiently on care that compares favorably with the employment-based schemes. After exploring several promising options, I have come to the conclusion that a robust primary care system to which the country's health system has been oriented could be the most practical answer to controlling costs and improving people's health and well-being at the same time. Specifically, a strong primary care system has the most potential to manage acute, chronic, and social conditions affordably, effectively, and equitably. And since it is situated at the border of the health system and the community, it should have the most opportunity to engage with several sectors in the community to foster a more resilient community system. Next slide, please. We can look no further than the COVID pandemic. As the recent pandemic can attest, primary care is the main responder in healthcare crisis. At least in Thailand, it is the case. The role of the UHC, therefore, is to ensure that primary care, which is closest to the community, is adequately financed and equipped and competent to provide comprehensive services, to coordinate seamlessly with specialty care and the community, and to adapt to abrupt situations. Some of the innovations that have been widely adopted during the pandemic, such as health literacy, virtual care, hospital in the home, hospital to home drug delivery, and coordination with, and various forms of coordination with private clinics, if used wisely, could be critical for primary care to meet its full potential. Next slide, please. So in summary, Thailand's UHC journey is never ending. It moves onward through the propelling force of the three essential elements that it cannot do without. Some brief pauses for quick reflections and readjustment occur now and then that result in new approaches for financing, for service provisions, and for engagement with stakeholders. Strengthening primary care underlined the scheme philosophy, why the three primary factors are always cultivated to drive any novel idea forward. And each new policy, when put into action, requires a vigilance to ensure that people can access care in a way that will not jeopardize providers' moral or the efficient use of resources. The advancement is slow, it must be admitted, and not all objectives can be achieved within the projected time span. Next slide, please. So to finish, I wish to offer some key points to ponder for low and middle income countries. Next slide, please. Okay. First, there must be a political will. If there is not, then it is imperative that a policy champion be found who is keen about UHC, knowledgeable about it, knows how to convince policymakers and the public of its merits, and rally them around this noble mission. Once a political will is obtained, and since we are talking about middle to low income countries, in my opinion, financing the policy via public money should be considered. And whether the people should have a more specific share in the financing of the policy, either before or at the point of care, depends on many factors. Most importantly, who among them will be obliged to pay and by how much without having to struggle to make ends meet. Determining when and how to collect and analyze health data and customer surveys should be part of the setup plan to help guide future payments and service arrangements. And for long-term sustainability, I think it pays to engage with the beneficiaries in every step of the policy process, from policy development to policy implementation, to make the UHC policy the policy of the people, for the people, and by the people, if I may paraphrase President Lincoln. So that is the end. I hope this is helpful, and thank you for your attention.
No, thank you.